to you, compliments of the season as well. Welcome to today's session that is titled Success Stories in Integrating Child and Adolescent TB into Global Fund proposals, one-on-one with COE members and Global Fund senior advisors. This session is part of the Union's Sub-Saharan Africa Regional Child and Adolescent TB Center of Excellence ongoing series to support member countries in preparing and reprioritizing Global Fund funding proposals in preparation for the upcoming grant cycle. This is Rita speaking, and I would like to welcome all of you to this session. A special welcome to the colleagues from Geneva at the Global Fund, as well as all of you who have decided to allocate some time this afternoon or this morning to this session. It's now my pleasure to introduce three people to you. Firstly, I'll start from Dr. Welile Sikonze, who joined us as the COE lead in mid-October 2025. She has wide experience in TB that runs over 15 years. She has also worked in HIV, COVID-19, and other infectious diseases. Welile will make the closing remarks today. Secondly, I would like to introduce our co-chairs for this afternoon. We have got Dr. Grace Mutamba Ire, who is the Director of TB Care and Treatment in the Ministry of Health in Rwanda, and Dr. Fungai Kavenga, who is the NDP Manager and Director in the Ministry of Health and Child Care here in Zimbabwe. Grace and Fungai are both extremely experienced clinicians and public health practitioners whose passion is to end TB. They have kindly agreed to facilitate today's session. And I would now like to hand over to you, Dr. Fungai. Thank you. Dr. Fungai, I saw you joining. Are you able to unmute yourself? Dr. Fungai, are you in or did we lose you? At the moment, I do not see him among our participants. I wonder if you, Dr. Grace, would be able to step in. Over to you.
Thank you, Dr. Rita. Now I will start by presenting the objective of today's session. First of all, is to provide a practical overview of key global fund, GC8, processes and prioritization framework, and reflect on lessons learned from the GC7 prioritization process, including what worked well and what challenges were encountered. Now, we will begin with a presentation from our colleague at the Global Fund, who will walk us through the GC8 process, prioritization, consideration, and key takeaway from GC7 prioritization. It is now my pleasure to introduce our first speaker, is Dr. Namdi Nwaneri. He is a specialist in the TB and focal point for TB surveillance, monitoring, and evaluation at the Global Fund, Geneva, where he provides TB M&E guidance, advice, and technical support to relevant teams within the Global Fund Secretariat as well as countries. in coordination with TB technical partners. As a physician with background in global public health and health policy, Dr. Nwaneri possesses experience from his work in clinical medicine and public health care delivery at his facility, national working with Ministry of Health, regional and international levels. Dr. Namdi, over to you.
Thank you very much. Good day to everyone. I will be making this presentation along with my colleague, Dr. Jamie Donsing, who is also here. I believe there will be an introduction for her before she speaks. It's our pleasure to be here. Can you confirm you can see my slides?
Yes, we see.
Okay, thank you.
Yes, thank you.
Thank you. So this is the outline that our presentation will take. As Dr. Grace rightly said, we will start with an overview of some of the observations which we noticed from the GC7 reprioritization exercise that the Global Fund happened at the Global Fund last year. And then some examples of best practices from that exercise, some of which we think would be useful as countries start to think and prepare for their GC8 funding request development. And then my colleague Jamie would give an overview of the GC8 processes and guidance as contained especially in our info note and the priorities for TB. And then at the end of it, we will stop for question and answers, and we'll be happy to take questions from colleagues. So just to give context, it's not news that there was a global reduction in funding for public health activities, especially last year. And it's not unique to any partner or donor, but in the case of the Global Fund last year, we had to conduct a reprioritization exercise, working with all the countries where we have GC7 grants to look at ways to find efficiencies with some of the reduced funding. The funding cuts that happened also provided an opportunity for better streamlining of activities within these portfolios, looking for better ways to integrate and innovations that could help save resources to be able to cover the existing needs. Some of the things which we saw, and we're looking at activities that were maintained or increased in scope following the reprioritization exercise, which ended in September last year. The first is, a lot of the essential service delivery activities, countries worked to try to preserve that because that's really paramount, right? So in the area of screening and diagnosis, essential TB service delivery, especially like health facility screening, PPM in some cases, targeted community screening and TB diagnosis were largely preserved. We did see increase in funding for molecular test reagents in a few countries as well. In treatment, care, and support interventions, we saw decentralized TB care and support activities were largely maintained. And because of the price reductions that we witnessed last year for bedaquiline, pretomanid, which are core medicines in the BPAL-M regimen, countries were able to gain efficiencies. And the revised forecasting allows for them to use some of those savings in a lot of cases to procure additional TB drugs to cover gaps that existed. In the area of key and vulnerable populations, in one of the countries, we did see very good translation of savings to increased funding for child and adolescent TB-related activities, including TB medicines in that country. And then community volunteers in refugee camps were funded to be able to fill this. Another example here is the CAS-TB, which is a community case finding in Uganda. They were able to secure funding until the end of last year using C19RM. In the space of program management, there was a lot of worry that it would completely be wiped out during a prioritization exercise. But what we saw was activities, by and large, key activities were maintained, including staffing, things around that, and some sort of budget efficiencies where they were able to achieve it. Community system strengthening provided the opportunity for increased budget for integrated community activities. And this is a theme which we would tend to see a lot of times moving forward as I go on with this presentation. And then for monitoring and evaluation, still following the spirit of integration, more integrated supervision and mentorship across TB, malaria, and HIV were noticed in some countries. But that being said, of course, we are talking about a reduced funding scenario. So some activities will naturally be either negatively impacted or not positively impacted, if I may put it that way. And they largely cut around financial incentives, sometimes scaling down on infrastructure, training, surveys, and shift from the way meetings and some of these in-person activities were conducted to virtual platforms. In the area of screening and diagnosis, it's important to note that at the beginning of the cycle, a lot of countries or some countries still had gaps in the TB diagnostic and cartridges for WHO recommended rapid diagnostic tests, right, in year 3. And typically the expectation for some of these countries is during implementation, if there are savings, those savings will be channeled to fund those gaps in the 3rd year. But of course, with the funding cuts, some of these gaps still existed, and so gaps in the 3rd year would still be there. And in the area of treatment, care, and support, DRTB treatment, social support for patients and healthcare workers, we did see reduction in a few countries. Cuts also in cash incentives for MDR-TB patients and stipends for community volunteers. For key and vulnerable populations, the first bullet there is really talking about a particular country where at the beginning of the grant cycle, they were really focused on scaling up activities for children and adolescents, including diagnostics. So they had put really increased amount of, or budgeted increased amount of resources, especially for this activity. But during the reprioritization process, everything had to be streamlined with no special preference given to any age group in that country, which we feel as something that impacted that important key and vulnerable group. And then activities and meetings linked to elimination of stigma and discrimination in one of the portfolios, we saw that it was deprioritized. In the area of lab systems, there were decreases in funding for lab information system development in some countries, or in 2 countries, sorry. EQA training dropped, and plans for integrated sample transport scale up in one of the portfolios had to be put on hold. And then for community and private sector engagement, community-based TB service delivery coverage was reduced in one of the countries, and PPM activities deprioritized. Lastly, in M&E and program management, at the beginning of the prioritization exercise, one of the guidance was for ongoing surveys, TB surveys, they can continue and they would end in the cycle. However, for new surveys which were yet to commence, they were deprioritized in GC7. We also saw decreased frequency in review meetings in some of the countries. And from the area of program management, some of the leadership trainings, TB courses, and research meetings were deprioritized. Now, that being said, there were unique cases where TB leveraged resources from either other components. That's when I say other components, it's HIV, TB, malaria, HIV, malaria, and RSSH grants. In some cases, from domestic funding and other donor funding being leveraged. I've highlighted a few examples here. One in Malawi, the government of Malawi made a commitment of 2.8 million to support the integrated sample transport in anticipation of the cessation of the US support. But beyond that, the country was also able to gain efficiencies of about 1 million from integrating some of these training, supervisory activities and meetings to cover gaps in TB case finding activities, which we feel is a good example. In Mozambique, there was transfer of savings which were generated from the RSSH grant to support community TB screening in one province that was previously supported by USAID. In Uganda, the RSSH grant funding contributed about 3.9 million to cover shortfalls that were experienced for TB commodities. But in addition to that, from the HIV grant, supports for the procurement of TPT and for PLHIDs and for contact, as well as some GeneXpert cartridges was realized in the country. In Nigeria, there are examples of efficiency gains of up to 8 million that was gotten from the revision process across board, and some of them used to reinvested to cover existing gaps in essential TB commodities. And in Thailand, the government stepped in to use domestic resources to procure IGRA tests, to fund cash incentives and cost of some key meetings, which were eventually removed from the grants. Now, in terms of some of the best practices, and we think these are things that we hope that countries continue to, further and think around as they prepare for GC8. In Nigeria, the national program increased investment in use of AI for TB hotspot mapping. This is just to enable a better targeted case finding rather than broad-scale case finding activities. If it's more targeted, has the opportunity to help them save more resources. And in addition to that, there were shifts from in-person to online training for healthcare workers. In Rwanda, there was an example of pooling of sputum samples for TB diagnosis, which was meant to lead to a decrease of 25% in the lab budget. In terms of adaptations, in Ghana, they modified their screening and diagnostic algorithm to ensure, or they plan to modify their algorithm to ensure high yield due to gaps, so that they can cover the gaps in the third year of the grant implementation for GeneXpert cartridges and have more targeted screening of KBPs. In Thailand, grant admin costs were reduced, and we're talking about travel, some of this training, to be able to fund core TB programmatic activities. And in Mongolia, there were some reinvestments of savings to support TB screening, optimization of diagnostic network, and fund essential TA gaps. And also, we also have examples of efficiency gain, more examples of efficiency gains. Indonesia is a good example where 9 million was saved from the fact that the country transitioned more than 80% of its DRTB patient cohort to the BPAL-M regimen. And so the need for enabler payments reduced in the country. In Myanmar, the same thing, the transition into shorter regimen led to a savings and of 2.8 million. But in addition to that, the reduced pricing also made more resources available, which the program, the PR later invested to fund DST and other life-saving interventions. Kenya had savings from meetings and printing of documents, which were moved to virtual platforms and online digital documents. In the area of integration, and this will be the last section in my presentation, there are examples from Malawi in integrating quarterly review meetings and monitoring and supervision. Pakistan is a good example where 7.8 million was saved from reducing HR costs, integrating services, and transitioning to BPAL-M. These savings were reinvested to cover gaps in children and adolescent-related activities in the country, as well as procurement of additional first-line medications. And lastly, Kenya, the integration of meetings, trainings, and utilization of community peer support enabled additional resources to be available for more programmatic activities. I'll stop here and hand over to my colleague Jamie, who will be presenting the next set of slides. Thank you.
Thank you, Nandi. So I'll be covering overview of the GC8 process and the TB priorities for GC8 standing for the Grand Cycle 8. That starts from 2027 onwards in terms of implementation period. Next, please. Thank you. So this is the Grand Cycle 8 timeline. In 2025 November, you may have heard Global Fund replenishment round was held, and we raised 11.34 billion in amount to be able to fund countries during Grand Cycle 8. So this was a good outcome given the funding circumstances, and we are hoping that the amount that becomes available to countries will be around 8% lower than the GC, the current Grand Cycle 7 de-allocation amount. So well, it is a dip as expected, but hopefully not as much as we were afraid of. So after that, we've developed the Grand Cycle 8 application materials. They are posted on the Global Fund website from December, and increasingly also along with the English language, we also have French and Portuguese, Spanish versions for all the core information documents. After the publication, simultaneously what's going on in December and January, we are running a lot of Grand Cycle information sessions, both for internal and external audience. I have left a slide on this deck later on in case you want to join those sessions or you want to view the recordings. They are all available on Global Fund website. The next main big step that will happen now is that in March, every country will get their allocation letter informing them how much amount they have for their next Global Fund grants, covering the Grand Cycle 8 period of 3 years. And then countries would be expected then based on the allocation letter amount, the amount that they have for the allocation, to develop funding requests and submit it in 3 windows in this year. That will be there'll be 3 windows available if they can submit during this period. And after that submission, we have a very compressed timeline because unlike in previous grand cycles, we are starting this whole step about our replenishment got delayed. Allocation letters were sent much later. Usually we send them in December of the previous year, but we'll be sending them in March next year. So much tighter timeline for them to go through grant making, submission for approval by the grants approval committee, and to be ready to start implementing in January 2027, which is when majority of the new grants will begin because their current grant ends in December. Next, please. So these are the 3 submission windows that I spoke about for this year, for 2026. There'll be several windows more in 2027, but window 1 is in June, window 2 in July, window 3 in October, and following these submission dates, the TRP reviews will happen on the months that are indicated on the other side on the next row. Next, please. Now let me get to the TB information note. So this is the main guidance document from the Global Fund to applicants to consider when they're developing the funding request. And you see the table of content there. There are general messages, bold prioritization of Grand Cycle 8 to sustain gains and maximize investments. This is common for all information notes for HIV, TB, malaria, and RSSH, or the health system one. In terms of the technical areas, this is covered in section 2, and this is really covering all the cascade of care and beyond, from screening to diagnosis to treatment, prevention, and collaborative activities. You will note that in section 2, we also have key areas related to community rights and gender under 2.6. Key vulnerable population, community systems, equity, human rights, and gender. And because of the focus on the need for becoming more efficient and to optimize resources, we have included country examples under best practice section, on which you can also look at. And then the Global Fund TB program essentials that were started in in Grand Cycle 7, they have been retained. Next, please. So what's changed in Grand Cycle 8 in TB information node? For the first time, the interventions are categorized as higher or lower priority for Global Fund investment. There is also a third category that we say what needs to be considered for optimization and efficiency. And the TB information note is aligned with the Grand Cycle programmatic reprioritization approach. So for those who have been through that process, they'll find a lot of similarities with the reprioritization exercise and what is coming in the Grand Cycle 8 node. TB program essentials, they were introduced in Grand Cycle 7, but they are now actually included as priority interventions in relevant sections of the information note, but we do have kept the table summarizing them as an annex in the document. You will see much more emphasis on integration, innovations, and value for money, and examples are included in the note. You will also know that TB guidance includes introduction of near point of care tests and sample pooling. We're expecting this will be approved by WHO. We also note the new WHO recommendations on DRTB treatment regimens, concurrent tests of TB diagnosis in people living with HIV and children. So these are things that WHO came up with new recommendations from the last Grand Cycle. So in this update for Grand Cycle 8, they have been included. So also in the Grand Cycle 8 information note, there is much deliberate mention of people in fragile and conflict-affected settings, people affected by extreme weather events and climate impacts. And they're included under the key and vulnerable population for TB and prioritized as a key population. Next, please. So I want to give you an example from the section on TB screening and diagnosis about the prioritization process. So when it comes to TB screening and diagnosis, we're saying the priorities for Global Fund investments include screening and diagnostic algorithms that are sensitive, accurate, and efficient, such as using chest X-ray with CAD-AI for TB screening, rapid molecular test as the initial test for TB. And also we are saying we need to start preparing for introduction and scale up of new tools, including near point of care tests and alternative sampling techniques, hoping those will be recommended by WHO. As in the past, the need to intensify screening and testing for TB in health facilities, to integrate TB services into essential healthcare packages and systems, and to implement targeted active case finding, focus on most at-risk population. So these are all the priorities. Examples of what's lower priority is to limit the use of sputum microscopy to monitor progress and deprioritize Global Fund investment to buy microscope for TB diagnosis. If required, this could possibly be funded from domestic fund, but unlikely Global Fund will invest in that. To limit mass chest camps among general population on untargeted active case finding interventions, because we see in some instances that once people have started active case finding, even when they don't get the expected yield, they continue to doing the same thing because this is an intervention has been included for all 3 years. So those ones should be stopped if they're not demonstrating the expected yield of TB cases. And examples under optimization, efficiency, and other consideration is to consider mapping and targeting high-risk groups and geographic areas with high incidence for hotspot mapping, and to consider options to optimize the use of test cartridges, such as pooling of sputum samples for molecular rapid diagnostics and upfront use of X-rays for TB screening to save costs on cartridges. Next, please. So these are other examples from other sections. I spoke to you about the screening and diagnosis already, which is on the first row. You'll note some of them are in bold here, and that is to indicate that the ones in bold are newly included in this Grand Cycle 8 information note. So on treatment, as an example, we're saying for DSTB, we should prioritize the 4-month standard regimen, also the 4-month regimen for children with non-severe TB. But on the other hand, we're saying lower priority is the 4-month rifapentine-based regimen for people over 12 years, and that is because this costs much more, the pill burden is higher, and the standard regimen works as well as this higher cost regimen. On DRTB, really the focus is to remain to use BPAL-M as the preferred regimen of choice. If not, then the new 6-month regimen recommended by WHO, and the lower priority are the other 9-month regimen also newly recommended by WHO. On prevention, as an example, we should be switching and buying more of antigen-based skin tests because they are more affordable than the eye interferon gamma release assay test. And when you need to prioritize who gets TPT, then we are saying if there are concerns about resource constraint, that we prioritize household contacts less than 5 years and PLHIV over people who are older household contacts or other risk group. And we're also prioritizing that countries start preparing for TB vaccine introduction. And in strategic information, the high priorities for real-time case-based surveillance systems, routine and periodic data analysis and use. And we're saying, on the other hand, the lower priority is things like TB prevalence surveys, household cost surveys, because these are costly. They take a lot of time, resources in terms of time of people, and they will only be considered in exceptional circumstances. For example, if there's co-funding for it from domestic resources. In the cross-cutting, I have mentioned about the special population groups we have mentioned there, fragile and conflict-affected settings, and weather events and climate impacts. And on health products, we're saying use standardized product specification and optimize procurement channels, so you are availing of negotiated price reductions instead of procuring locally for high purchases. And there are other examples of lower priority on purchase of vehicles and non-essential equipment, renovations, international conferences, commemorative days such as the World TB Day. Next, please. So this is Global Fund's TB Program Essentials. I think just a reminder for those who may not have seen this before. There are 13 program essentials at the table on the right side. I don't intend to go through them. You can look at it in the information note. So this has been retained. They are nothing really new because they derive from normative guidance. But these are things that we think represent a summary that best aligns with the key priority interventions of the Global Fund, and they are critical to really meet the Global Fund strategy and TB targets. But also to note that the importance or the relevance of these program essentials will depend on the country context. For example, there's a program essential on the need for private sector engagement, but we also know that there are countries where private sector is not a large player, and then for that context, maybe countries may not prioritize investment to engage private sector because it's not relevant. Next, please. So this is the what I was talking to you before. We are holding GC8 information sessions. You see the session title, the dates that they were held, and at the bottom of that you will see a link there, because the last slide of this slide, registration, recordings, and downloadable slides are available through that link there. You can register for sessions that are not yet held. You can look at the recordings and presentations for sessions that are already held. And my last slide is more also about the information sessions and the documents where you can find them. These are all the core guidance for Grant Cycle 8, and you will see them listed there. They are English, Spanish, and French, and by clicking them, you can get those documents. So with that, I thank you very much, and I hand over to the chair. Thank you.
Thank you, Jami and Namadi, for the nice presentation. Now we are asking the country team to ask a question, share reflection, and release practical issues encountered during the GC7 or anticipated for GC8. Over to all. I can start my question for Rwanda. For Rwanda, we are currently in the process of developing the TB-NSP 2027-2030, which is expected to be finalized by the end of March 2026. Following the completion of NSP, we will initiate the global GC8 process. Maybe we will be the second window. We submit the second window in July, if it is possible. The current TB-NSP will conclude in June 2027 under the National Strategic Financing Result-Based Financing Model. As you know, the USG support has decreased, especially for childhood TB management, where it was largely supported by USG funds, but also for TB diagnosis and screening. As I have seen in the presentation, the fund will be decreased, especially for high-risk group. You will increase only for refugees. It will be prioritized, but for prisons at the high-risk group, it will not be a priority for the GC8. I would like to know the reason, and because, as you know, in prisons or at the high-risk group, we still have many TB cases, but you focused only for refugees. I would like to know the reason behind.
Thank you. I'm first of all, it's good to know that the national strategic planning is going on well, and the NSP will be ready to enable the country identify which interventions they would like the Global Fund to fund for GC8. So that's a very good way forward. Thanks for the update. To your question, I'm not sure where you got the information from. We are not deprioritizing prisoners or any group. Maybe it was when I was showing some of the outputs from the GC7 prioritization exercise, and I mentioned that in one country, because they were prioritizing a refugee camp, they continue to fund community volunteers that were helping with the screening in that camp. That doesn't mean in that country other KVP activities were not taking place. And for sure, that's not the message for GC8. From the presentation Jamie gave, it's quite clear. And if you check the information note, which will guide the development or the funding request, the Global Fund stance on this is quite clear there. So I hope this clarifies, and please feel free as you are prioritizing to structure your funding request based on the prioritized key groups in your country and use that to generate the funding application. Jamie, feel free to jump in if you want to complement what I've said.
I think you've covered it all, Namdi. I think what Namdi was presenting was examples of how people prioritized, and so maybe I think we're getting confused with what is the guidance from Global Fund. So the Global Fund guidance is very clear. If you look at the key vulnerable population sections of the information note, you'll find over more than 20, 30, 2.6 section. In that section, you have a table of the main groups of people whom we consider key and vulnerable population. And I think everybody is very inclusive. Everybody is included there. That's why I mentioned that in addition to the known key and vulnerable population groups, this time we also added people who are impacted by climate. So there are many, many groups listed there. You have to define in your own country who are your key and vulnerable populations that needs to be targeted through Global Fund investments or other investments so that you're able to improve access and provide service they need. Yeah. So Global Fund will not dictate for you who is a priority KVP population for you. You have to do that at the country level. It will be based on your NSPs and other NTP guidelines.
Okay, thank you. Thank you. I understand. Other questions?
Maybe one comment I can make for Rwanda, because I'm aware that over the last few months and early, I think from 1 year ago, you conducted a key and vulnerable population size estimation
Yes.
and a match analysis.
Yes.
I joined some of those discussions, which has helped you to identify what the true picture is in your country, which ones are priority. And so for sure, as you are developing your NSP, we imagine that this would feed into that document and you would use it for your prioritization. So please, just to reinforce what we've said here. Thank you.
Okay, thank you. Yes, we have already a report, final report for TB match analysis, and to be considered during the development of NSP. Yes, thank you. I have another question. What aspect of the G7 prioritization process were most challenging for child and adolescents TB in general from Global Fund report?
Okay, so again, these discussions are held at country by country. It's at country level, right? The principal recipients and stakeholders sit down to discuss this. But based on some of the comments which I saw when looking at feedback from our advisors, in one or two countries, I gave an example where in one country, the children and adolescents, the coverage in that group was particularly lower than other age groups. And at the beginning of GC7, they had intentionally dedicated additional resources to scale up diagnosis, treatment, especially in this group. But of course, with the reduced funding, such strategic thinking, they had to scale down a bit there. And so those kind of trade-offs become challenging for a portfolio that intentionally wants to drive coverage in a particular group, but just because of reduced resources, it has to kind of even it out across all the age groups. So I think that doesn't, as we go into GC8, it does still remain valid for countries to still use their own data to do the planning and allocate resources to the places where they will be able to drive the most impact and improve coverage, including in children and adolescent groups. Taking into consideration new innovations that are there, new tests that can be scaled up and so on. So that's a high level thing I can think about that's for sure challenging in some of these countries that intentionally want to drive access and coverage for children and adolescents.
Thank you. Another question is, what point require more clarification or guidance as we prepare for GC8? The guidance you can give us for preparation of GC8. especially for children and adolescents.
I think maybe I can start and I'll ask my colleagues to also chip in. So what specific in the information note for children from the top of what I remember is that we want people to use the best sensitive tools to diagnose TB in children. And so we are saying, for example, molecular tests fine, but not just for, also for stool sample, other extrapulmonary samples, those ones you should be prioritizing your investment upon. The use of the 4-month shorter regimen for people with non-severe TB, that's also the fix those combinations, child-friendly formulations, even if that costs more. Global Fund is very happy to be buying those products. So I think I can remember those specific documents are here, but I would ask my colleagues who are on the call. Anna, Rania, please come in.
Yes. Let me close. Can you hear me now? Yes. So sorry, we are in the same room, and so it's complicated to manage the microphones. No, just Jamie already highlighted those areas that everyone knows, no, that are very much priority for children. But if I may also suggest what for me is important this year already, this month already, trying to learn from what has been done already, because these activities like the treatment decision algorithm for children under 10, the use of stools for TB diagnosis, and also the shorter regimens for drugs susceptible, not severe TB, or even the shorter regimen for TPT, have been introduced almost everywhere, I think. But the level of introduction maybe is not nationwide in some countries. And maybe also we don't know very well if it works well or not, or what needs to be fixed in order to make these activities to work better. So I think this is the time also to try to learn from what has been done so far in these specific pediatric specific components that have been new during the GC7, and so we can really make corrections or decide how is the best way to scale up each of them, and if it's appropriate to scale up and how to scale up, no? Especially the also treatment decision algorithm that I think may vary also country by country according to the context. So for me, it's really important now try to really look at what has been done so far and trying to use the evidence we have to inform in the best way the funding requests on these specific pediatric specific components. Thank you. I don't know if Gran, you want to add anything on your point of care or new tools that can come back. Maybe could be. Thanks.
Okay, thank you. Other colleagues can help also to share the experience, how they develop the NSP or where they are for the GC8 process of request of funds.
Maybe while people are thinking, just to add to Anna's point, and I put something in the chat, is around kind of, particularly as you're developing NSPs, as these often bridge across our funding request cycles. So we are aware there's a number of countries who are undergoing modified program reviews in preparation for NSP updates, or are in the process of an NSP update, which I think you see that document is key to feeding into the funding request processes, and just being sort of aware that there are a number of new approaches and new technologies that may be that we're expecting WHO guidance on in the next 1 or 2 months, particularly in the diagnostic space, and just to sort of be cognizant of how you may want to include this into your national strategic plan and costing approaches. One of the key areas of the near point of care test and alternative sampling techniques, such as tunnels. You may or may not be aware there is some evidence in children. Unfortunately, as we've seen before, often this evidence is not as plentiful as what we see in adults, but a lot of the evidence has been in adolescents, so this is definitely technology that could and should be available to older children and adolescents. The evidence on children is being worked on, but I think it is something to bear in mind and has a very different cost structure to our other molecular diagnostics, which to Nandi's point and what Jamie was making, when we are in this situation of resources having to cover, we're having to do more with less. Some of these potential cost-saving approach is something we'd like countries to be aware of. If you do want to find out more about these new points of care tests, I'm very happy to be the focal point, so you can contact me, or if you want to go to your global country team, then we can also support with presentations and information on this product that may help you and your national strategic planning team thinking about how the appropriate introduction and scale up would be.
Okay, thank you. I don't know if Dr. Fungai Kavenga is available now to give us experience for Zimbabwe or...
Okay, thank you very much. I just wanted, thank you very much for giving me the opportunity. I just want to share our experience in terms of prioritizing childhood TB. So one of our biggest challenges has been fitting priorities within a constrained envelope, particularly juggling between adult TB, HIV, and cross-cutting health system investments. So child and adolescent TB then was then perceived as already covered under broader TB activities, which made them vulnerable during prioritization. So I just wanted to understand from colleagues on the call if they can share their experiences on how they worked around this challenge or a similar challenge. Thank you, and over.
Someone else to give the country experience for childhood TB management.
Maybe I can say something. I'm not sure it's very childhood TB specific. The only childhood TB specific probably that I remember has been in some cases in some countries the challenge of ensuring training specific on childhood TB issues that could be quite relevant when you introduce new approaches like the treatment decision algorithm, the use of stool, even if maybe it's a very short training, but still you need to organize it. That's why I also said before that I think it's important now to check what works, what needs to be strengthened and improved, because in some cases there was the need to rationalize very much components like training, like supervisions, and maybe integrate training and supervision, and therefore reducing that specificity that maybe is needed when you address specific groups like children. So in some cases, few that I remember, specific TB training have not been done because have been integrated within broader training, and maybe also reduced duration of training and integrated supervision or reduced supervision or no supervision at all. So probably these are components that have been somehow sometimes affected. In terms of solutions that have been found to use the limited resource, the more limited resources than before. For instance, some countries have been has been necessary a sort of geographical reprioritization with the identification of a package of services, full packages of services to be offered in few high volume sites or high burden provinces, and the reduced package of services in sites with smaller volume or lower burden of the disease. This is an exercise that is also time consuming and not easy to do. And sometimes it's been very useful and needed, and maybe can be still useful also for the GC8, no? Depending on what will be the resources available. Thank you. I don't know if other colleagues want to complement. Thanks.
Okay, for Rwanda, we have already developed e-learning because, as you know, it is very important to build capacity and the confidence for healthcare providers on TB management. And we have an guideline on the platform for e-learning, and we developed also telementorship to support the healthcare providers at a decentralized level, but we still need face-to-face for practice for how to read TST, IGRA, and so on, but we reduced funds allocated to the supervision and mentorship. We develop also, we integrated childhood TB management in MCCH services, IMCI, ICCM, and everything, and it helps us to develop, to train other nurses in charge of other services to help us to screen TB and to help us also for follow-up. That is our experience, Rwanda experience for TB management. Yes.
Paul has a hand up. Please go ahead.
Yes,
Paul,
someone.
and Stephen also had his hand. Yeah.
Yes.
Thank you so much. So I would like to share our experience from Lesotho. We currently have ongoing TB campaigns or outreaches that are led by the HMTs. So this is where we try to do case finding in the community. So we have incorporated childhood TB by going to to schools and preschools, that informal ones, that where we can find children. There is also establishment of childhood TB technical working groups in the hospitals in the country, so that we focus on groups that are working with children in the hospital, namely the MCH, IMCI, PIDS or ward, and also ART corners, where we are now in the process of establishing such. We have had one session with one of the hospitals where we have held a session with them on childhood TB. So these are planned to continue for the rest of the year. Thank you.
Another one, because it was 2 hands. But I have another challenges we have in our country. The treatment success rates among children from 5 to 14 years still low compared to under 5. As you know, it is very easy to capture the children from ICCM, IMCI services, but for the children above 5 years, they are in the OPD service like other adults, and sometimes it is not easy to use the algorithm for children. I don't know if other countries have a specific policy for the children from 5 to 14 to share experience for Rwanda, as we are in the process of development, so it can help us to adjust our national algorithm or strategy. Thank you. If Lesotho has something how they proceed to reach the children from 5 to 14, it will be better for us. Because we don't have a specific services for adolescents in TB service. Yes.
So in Lesotho, we have adolescent corners in different hospitals. This is where we get our adolescents. We also have Baylor, which mainly has taken over most of our adolescents. But even in the clinics, we do have adolescents. So the algorithm that we use is still the same one that is from WHO, where we use chest x-ray where available, and where it is not available, we just do the normal symptom screening. And since I will check the data as to the segregation in terms of whether we are getting more adolescents, but that should be the case, and children who are less than 5 years. But we are making use of these adolescent clinics in order to identify more children who come here. So for Baylor, there is currently a project that is ongoing on stool testing and optimizing TPT uptake amongst PLHIV who are adolescents. So those are the things that we are currently doing as a country. We focus on these adolescent clinics where we have nurses who have been trained on TB and are actively searching for adolescents in their departments.
Okay, thank you. Okay. Someone else? If there is no other question, I can give the floor to the Wedile for closing remarks.
Thank you very much, Dr. Grace, and thank you to our Global Fund colleagues, facilitators, and all participants for this very rich and engaging discussion. The insights shared today reinforce the importance of early engagement, clear prioritization, and strong advocacy to ensure that children and adolescents remain central to TB investments under the Global Fund, but also domestic and other investments that are made available to us. Just to note that the COE remains committed to supporting countries throughout the GC/AIDS preparation process and beyond. And we look forward to continued learning and collaboration in the upcoming sessions of this series. And if you have, we would like to reach out to any of the COE coordination team. If you'd like to reach out to Dr. Grania, as she's mentioned, and I'm sure through your country teams as well, you can reach out to the relevant focal persons. The COE remains available to engage in any discussions or provide clarifications for any questions that you may have. Once again, thank you all for your active participation, and enjoy the rest of your day, evening, and morning. Thank you very much. We can end the meeting.
Thanks a lot.
Thank you,
Thank you,
Edile.
everyone.
Thank you. Thank
Thank
you.
you.
Bye. Bye.
Thank
Thank
you.
you very much.
We would like to have the
Thank
presentation.
you. Bye.
Right.
The presentation early as possible because it was very, very informative for us.
Yes. Presentation will be made available.
Yes, it was very, very
Shit.
informative.
Okay.
Thank you.
Thanks.
you.
Bye, everyone.
Bye.